So this final video is going to talk about some of the other drugs, and these don't really fit into any specific category, but they are pretty useful for bipolar disorder. They wouldn't be kind of the first go-to drugs, um, but they have historical precedence. These are old drugs that have been used for a very long time, and you'll probably recognize some of them. First one's going to be lithium. This is elemental lithium. This is first used to treat bipolar disorder, depression, as well as mania. Several mechanisms of action exist, of course. It can both promote GABA but inhibit dopamine and inhibit glutamate. And of course, we're looking at promoting GABA, which is inhibitory, and inhibiting the excitatory neurotransmitters, dopamine and glutamate. And of course, the disease that is associated with each of these neurotransmitters is depicted there. What is interesting about lithium is that it's got a really narrow therapeutic index, and the toxicities can manifest very quickly. And these toxicities come about abruptly due to changes in volume of distribution. So this drug tends to distribute into total body water, and it's excreted in sweat. What's interesting is that acute dehydration, heavy exercise, a diuretic overdose, changes in the fluidity of the patient, so think of like an acute diarrheal infection. All of those abrupt changes to physiology can really alter reabsorption and increase plasma levels of this drug, and they can be very and they can see very toxic levels very quickly. This drug, interestingly, doesn't cross the blood-brain barrier, as well as like sodium or potassium, but changes to the blood-brain barrier permeability can produce CNS effects very quickly, and that's best demonstrated by acute alcohol ingestion. Of course, when the patients are drunk, alcohol opens the blood-brain barrier, and of course, then this drug can get in. So it's really problematic. It can work in patients that are well controlled, but they just have to be educated that if they experience any kind of acute dehydration or heavy exercise, even going for a walk on a really hot day can really push them over the edge, and then they can experience toxicity. Another drug, carbamazepine, which you know from the previous case, also has the ability to block the neuroepinephrine transmitter because carbamazepine is structurally similar to imipramine, which is a tricyclic antidepressant. This drug can also alter the serotonin levels, and it also has an effect on adenosine receptors. And so technically, it is an anti-epileptic drug, and it's been used as such for, I don't know, 100 years, but it's also a mood stabilizer. And so these patients also, that are being treated for epilepsy, also experience a stabilization of their mood. And so this is kind of how this drug was kind of sent to the CNS diseases. Valproic acid is another kind of broad-spectrum anti-epileptic drug. Structurally, it's a fatty acid molecule with really low potency. In order to get any kind of effect, you have to administer hundreds of milligrams of this drug to produce even some minor activity. From a mechanistic standpoint, this drug has GABA activity, and it also inhibits glutamic acid decarboxylase. Okay, so what do we do with all this? And so this just kind of helps you kind of put things into perspective. If you're following along through a textbook or some other type of media, you know that we haven't touched on all the drugs for depression. And so what I've decided to do, because the CNS or the psychiatry components were so long, is I cut the first group of pharmacology lectures down a little bit. We will talk about all these drugs at some point, but there's no need to talk about every single drug in the first lecture. Okay, and so the other things to kind of keep in mind is that and Dr. Dance talks about this in a little bit more detail, is, why does the patient have depression? Is it a deficiency in norepinephrine? Is it a deficiency in serotonin? Is it a deficiency in both? Are there symptoms that are specific to these deficiencies? What does their sleep disturbance look like? Do they have suicide ideation? Should we be targeting serotonin? And so kind of the first line agents for depression include SSRIs, which we've talked about. The second generation include SNRIs, which we have not talked about, as well as other drugs listed there, such as mirtazapine and bupropion. Second and third line agents include tricyclic antidepressants and monoamine oxidase inhibitors, and we will talk about them shortly. And so this is kind of just a brief kind of overview of the main drugs for bipolar disorder and a couple of drugs for depression. Okay, and then this next slide you can read by yourself because this is really more kind of looking at depression. And so, we're going to have to cut up some of these lectures and move things around, but at least you can be thinking about, excuse me, how we can treat these patients and what are the factors that kind of play into a role in terms of what's the better drug. All right. So that concludes this lecture on pharmacology for the Sarah O'Neill case, and we'll continue through psychiatric pharmacology in the next few weeks. Thank you.